I'm John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital in New York, and it's great to be here and give you some updates from the ASH 2024 meeting and other areas of lymphoma. So we're going to work through a few different areas of lymphoma, but first, diffuse large B-cell lymphoma being the most common subtype of lymphoma and obviously the type that is curable. And so knowing updates in this area is really important because you obviously want to get it right, particularly in a patient that has curative potential so that we stay on track for that best chance of cure. So most of you, I think, are familiar with the POLARIX study, one of the first studies to really change the initial therapy for some patients with diffuse large B-cell lymphoma, frankly, in a couple of decades. So at ASH 2024, we saw Gilles Salve presented the 5-year update of this study. And I think there's some interesting points from this trial. So I'll start first with the schema. This took patients with previously untreated diffuse large B-cell lymphoma between age 18 and 80, IPI 2 through 5, good performance status, basically randomized them to the antibody drug conjugate polatuzumab with R-CHP versus the standard R-CHOP. So swapping in polatuzumab for vincristine, and this has been published in the New England Journal of Medicine in 2022. What we saw at this update was really the 5-year data and a few other analyses in that regard. And so, as you likely know, this was generally a positive study, and the update continued to be a positive study. The primary endpoint was focused on progression-free survival, and you can see that there was about a 5% difference, 5 to 6% difference in progression-free survival in the overall population. So given that these were patients that were IPI 2 through 4, again, I think reasonably good results, and certainly the PFS benefit that was seen previously at 2 years continues at 5 years. One notable aspect of the study is that there's no difference in overall survival. And you can see that while the numbers are a little different, basically they were non-significant. This probably reflects the fact that we do have better and better agents and regimens for second-line therapy and beyond for patients who happen to relapse with DLBCL. But nonetheless, if we can save 5 or 6% of patients from relapsing, that's a good thing. And the toxicity of this regimen was quite similar. There was a little more, back in the New England Journal paper, a little more cytopenias and a little more neutropenic fever, but really very similar, no real difference in neuropathy. And so a very comparable regimen with regard to safety, yet better in progression-free survival. One of the things that's come up and gets a lot of discussion in lymphoma circles relates to the fact that do we think about different subgroups of patients with DLBCL differently? Is there a subgroup that seems to benefit more from the swapping in of polatuzumab for vincristine? A number of different subgroups have been looked at, and you see a summary on this slide. And basically, as you all know, no doubt, the large cell lymphoma has been looked at in the activated B cell and germinal center B cell subtype. There are lots of updates in those classifications over the last 10 or 15 years, but ABC, GCB remains one of the subsetting that has been looked at in a variety of studies. And as you can see in the highlighted area here, the ABC subgroup of diffuse large B-cell lymphoma seems to be, there's also a surrogate non-germinal center, if you're using immunohistochemistry as a rough surrogate for that. You see that there is more dramatic benefit, more significant benefit with polatuzumab swapped in. And on the other hand, you see the GCB subtype or germinal center subtype didn't seem to benefit as much. So this has led a number of people to say, well, we did a study in the previous slides that looked at the entire group of patients, but perhaps we should focus in the use of this drug perhaps just in the ABC subgroup. And in fact, another study at ASH led by Cliff and colleagues basically also supported this idea, meaning that there was no difference in outcome in patients receiving polatuzumab by the cell of origin. You would have expected with an R-CHOP type regimen or other chemotherapy-based regimens that the non-germinal center do less well. When you swap in polatuzumab, There's no difference in the cell of origin. The non-germinal center and germinal center seem to do similarly, suggesting that polatuzumab may be correcting for this less favorable outcome in the non-germinal center subtype. And again, this argues that particularly if you see a non-germinal center subset of diffuse large B-cell lymphoma, a patient that falls into that subset, that polatuzumab may be of particular value. And so I think more and more this is becoming an issue of interest and something to keep in mind in your practice, particularly if you see this subset of patients, to perhaps especially consider polatuzumab in that group. So the next area that I want to focus on, and we're going to come back to over and over really in the rest of this presentation, is the bispecific antibodies. These have really changed therapy for large cell lymphoma and follicular lymphoma, providing other options for patients. We have a number of CD20, CD3 agents approved. I won't talk about lenalidomide, which is more relevant for BALL, but mosunetuzumab, glofitamab, and Epcoritamab are approved for different subsets of B-cell lymphomas, and odronextamab, another CD20, CD3 bispecific antibody, is fairly far along in clinical development. And so a lot of data over the next few minutes about how these agents may work in different settings. So first we'll start, again, sticking with the diffuse large B-cell lymphoma theme, Epcoritamab that I just showed you, the idea being, well, gee, if you have a frailer patient, an older patient, perhaps we can avoid chemotherapy and give them a bispecific antibody instead as initial therapy. This was a study presented at ASH looking at this specifically. The design was really taking older patients over the age of 80 or over 75 with comorbid conditions. And this study randomized in a kind of a randomized phase 2 approach, Epcoritamab given subcutaneously. You see the schedule on the upper right, or a subset of the patients also got lenalidomide as part of that. And this was a small study, primary endpoint CR rate, looking to see, would this be a reasonable approach for patients with upfront DLBCL, again, falling into this group. Small number of patients, 45 overall, divided by the two groups. You can see that about half of them, give or take, were between 80 and 85. Another 40% were over the age of 85. You see that the majority had high-risk IPI 3 through 5. This was a reasonable approach. The overall response rate was 70% to 80% overall. The majority of patients had CRs. And you can see in the bottom right, with relatively short follow-up, these at least lasted 6 to 12 months. Again, whether or not this is a curative approach, again, remains to be seen. We expect a curative approach in large cell lymphoma, or we aim for that. The other approach, the other question here, I think, is, could these patients have gotten chemotherapy, even mini R-CHP or some other approaches? So I think it's hard to know where this fits, but certainly provides some support for the idea of using a bispecific antibody early in the course of therapy. And so, again, a good starting point. I don't know that this is something is ready for use in widespread practice, but we'll see where this goes as part of upfront therapy. And there are a number of other studies looking at trying to use a bispecific antibody, usually in combination with chemotherapy, as part of upfront treatment. And this data at least presents some data in support of that approach. Now, the STARGLO study, I think, is an important study. This was published in The Lancet last year and is being updated at ASH. We'll get to that in a second. This was led by Jeremy Abramson. Took the approach of, you're a patient with relapsed large cell lymphoma, maybe not eligible for an auto transplant, or maybe have been through some other therapies, frailer, et cetera, and randomized patients to R-GemOx, which is one of the standards for this population. Admittedly, there are several, versus GemOx without the rituximab, and glofitamab, another CD20, CD3 bispecific antibody. And you can see this was a fairly decent sized study. It was a 2-to-1 randomization, so overall somewhere around 250 to 300 patients. You see the treatment schema here, and again, an older group of patients ranging up to the 80s, but a median age of about 88. And again, more than half of the patients had primary refractory disease or disease refractory to their last therapy. A small number had prior CAR T cells. And so this was a positive study. Again, this was published in The Lancet. Worth noting in your practice, if you're somebody who uses GEMOX, and I think if you're out in the community, maybe you don't have quite the same access to CAR T cells, the idea that you can take a patient with second line or later diffuse large B-cell lymphoma and get a pretty good control of disease with progression-free survival, as you can see, in over 40% of patients going out 2 years. The medians here you see summarized on the right, median PFS being about 14 months versus just under 4 months. So again, this is clearly a difference. I think one question would be, what would you get with the glofitamab alone, which is a pretty good therapy, and we'll come back to that a little bit later. But a positive study, and one that I think can give a durable response for a subset of patients that might not have great other treatment options if they were not approaching a CAR T cell strategy for various reasons. This is the overall survival, and in fact, perhaps even a little more impressive that there was an overall survival benefit in this study. So again, encouraging here, and again, something relevant to our practice. Now, what was updated at ASH was an analysis of patient-reported outcomes. Patient-reported outcomes, obviously very important, particularly in a group of patients that are maybe not curable or as less curable, and an elderly, more frail group of patients, knowing how the patients felt and tolerated the treatment. There was a lot of data in this analysis, but you can see the pain scores and the lymphoma symptom scores, at least stable, if not perhaps a little improved in some settings. I think the takeaway here is that, and this was short follow-up, this is really while patients were on the therapy, that their quality of life, pain scores, lymphoma symptom scores were not hurt in a meaningful way, is kind of my takeaway, by the addition of glofitamab. So they got disease control, they got more responses, progression-free survival, overall survival, with a symptom score that was roughly similar. So I think, again, the cost of that benefit with regard to the tumor seemed to be pretty acceptable with respect to the patient's perspective. So I talked earlier about glofitamab in the relapse setting in combination with GEMOX, and I raised the issue about, well, what about glofitamab alone? And this is extended follow-up, 3-year follow-up of a pivotal single-arm study looking at glofitamab as a single agent in patients with recurrent B-cell lymphoma, updated by Michael Dickinson at ASH. And to remind you, this approach, this has been presented before and published with shorter follow-up, that you get a day 1, day 8, day 15 infusion of glofitamab, and then you switch to a 21-day cycle. You also get some mosunetuzumab as part of that to minimize the cytokine release syndrome. And this was basically efficacy and tolerability as the endpoints of the study. And just to highlight that if you went into a CR, and again, you know, one criticism I have of this study in the presentation that was raised in the session actually is that you're seeing just the complete responders here. You're not seeing the whole population. So when you look at this very nice curve, it's duration of CR, it's not PFS for everybody. So of the 40% of people who went into a CR, the efficacy was quite good. Obviously, that's a minority of patients, but if you went into a CR, you can see that these can be quite durable responses and complete responses, and one might even argue perhaps even curative therapy for a subset of these patients. And so, again, more data suggesting that glofitamab can give you a durable remission for a subset of patients with recurrent diffuse large B-cell lymphoma. Again, as I referenced, there are other bispecific antibodies that are playing in this space. This is odronextamab, another CD20, CD3 bispecific, looking at patients with DLBCL progressing after CAR T-cell therapy. This is the ELM-1 study presented by Matt Mattisar. Similar sort of design, but again, focusing here on the patients who have had CAR T-cell therapy and progressed. And when you look at this study, again, it was about 60 patients, give or take. And you see that all these patients got to CAR T, important. All these patients progressed after CAR T, important. all these patients could go on another study after CAR T. So there is a little bit of selection going through all this, but you can see at the bottom here that the majority had high-risk disease, a median of 3 prior regimens, and everybody, or at least half the patients, had some element of refractory disease. You can see that they had the range of CAR T cell therapies and progressed at various points in time, most of them after 6 months or so. And the responses could occur. The overall response rate was about 48%, so about half of patients responded to odronextamab. And you can see that of the responders, so you're looking at the half of patients who responded on these curves, you can see that, again, some of them, about half of them, were durable and, not surprisingly, better if you went into a CR. And so, again, the evidence that a bispecific antibody can be useful after CAR T progression is quite meaningful here. Just to throw in one bit of information, another bispecific antibody, CD19, so a different B cell target, CD3, bispecific. And again, similar kind of design. You can see the treatment regimen at the bottom here, very similar, given day 1, day 15. And this was a dose escalation study, so we're still sorting out and seeing data at different dose levels. But across the board, depending on patients, whether or not they had or had not had prior CAR T, response rates are in the 50% range, depending on the dose, CR rates in the 20 to 40% range, and tolerability on the bottom right, as you would expect. Again, here, mostly grade 1 cytokine release. So generally a favorable or comparable toxicity profile for this group of patients. So this is an agent I think we're going to hear more about over time. We'll come back to it in follicular lymphoma in just a minute. Now I want to pivot a little bit. As you all know, this study touches on 2 exciting areas. One is circulating tumor DNA. Can you predict outcome, perhaps obviate the need for imaging in patients with large cell lymphoma in remission? Or can you use circulating tumor DNA to escalate therapy as a marker to drive escalation of therapy? This is something that, as you all know, is being applied to a lot of different oncologic settings. This applied this approach to the setting of patients with getting second-line CAR T cell therapy versus standard of care auto transplant in the Transform study. This, at this point, is an older study. Just to remind you, this was patients with early relapse within 1 year large cell lymphoma, randomized to lisocabtagene as a CAR T cell approach versus standard of care. The details of the randomization, you likely know. The CAR T cells won here, and that become the standard of care for patients with early relapsing large cell lymphoma. This analysis looked at the value of ctDNA sampling at different time points. You can see at baseline when the patient started their second-line therapy, and then at a couple different time points after. And the bottom line of this study is summarized here, that regardless of what time point you look at, even early, even late, that the patients who were MRD negative at any one time point did better than those that were MRD positive, looking at, again, circulating tumor DNA. And so to me, I mean, this is not surprising. We've got more and more data out there saying that ctDNA correlates with a better or worse outcome. But what this tells you is that perhaps we can use this information if we knew a patient was highly likely to relapse, and you could argue the MRD positive group at all these time points only had a 25% chance of a long-term remission. You might take these patients and do something else with them, give them more therapy. You'd obviously have to show that that was better than waiting for them to relapse. But if you had a 75% chance of relapse, it certainly is appealing to say, well, why do we wait for that? Why don't we think about trying to do something more, perhaps when the disease burden is only molecular at this point in time? And again, it also suggests that these might be patients that could be approached differently as far as their surveillance after they complete therapy by the degree of monitoring as evidenced by whether or not they were MRD positive or negative. So I think just one example of how MRD might be useful in different settings. So now to pivot to follicular lymphoma, what's new there? This is probably the second most common type of lymphoma that you all deal with. Again, as we talked about in large cell lymphoma, the idea of using a bispecific as initial therapy for follicular lymphoma. These are data with mosunetuzumab, as you know, a CD20, CD3 bispecific approved for relapsed or recurrent follicular lymphoma. This is single agent as initial therapy, a subset of patients here saying, we sometimes use rituximab as a single agent. We often use chemotherapy or R-squared. What about single agent mosunetuzumab? This is a study. It took 78 patients. You can see the parameters here. Most of them had lower risk FLIPI disease. And you can see that the majority met Guelph criteria through various parameters. And the overall response rate was quite high, 96%, CR rate high, 80%, 1 year progression-free survival, 90%, so quite encouraging. Obviously, in follicular lymphoma, you need longer-term follow-up, so how this is going to compare to some of the standard therapies would obviously take randomized trials, but this is encouraging single-agent data for upfront mosunetuzumab. And I'll just highlight for the audience across the country through the cooperative groups, the SWOG 2308 study. This is a randomized phase 3 study comparing rituximab, commonly used in low tumor burden follicular lymphoma as a single agent, versus mosunetuzumab. So this will give us some data. This is a large national study. Will give us some data on how mosunetuzumab compares to rituximab as initial therapy for low tumor burden follicular lymphoma. So probably going to be more toxic because it's a bispecific, probably going to be more effective because it's a bispecific. How that compares and what are the trade-offs, I think will be very interesting in this randomized trial. And can we potentially get some very durable remissions in this group of patients? And you might argue an immunotherapy might work even better early in the course of the disease when you haven't been beat up by chemotherapy and have immunosuppression from whatever chemotherapy you've had before. So this will be an important and interesting study. Odronextamab against CD20, CD3 that I referenced earlier in large cell lymphoma also has been looked at in previously untreated patients. This is the Olympia study, and it's again comparing in a similar fashion in higher risk patients, odronextamab versus rituximab chemo being more standard in higher risk patients with follicular lymphoma, and that study is ongoing. There's some initial data, small experience, but initial data in the bispecific alone, the odronextamab alone, the first 13 patients looked at in this combination. And you can see high overall response rate, 93%. All the patients had CRs. And with very short follow-up, but nonetheless encouraging, all these CRs were durable. And so again, I think this is another approach. These are very early data, small study, but certainly an interesting approach that we'll see more of for upfront follicular lymphoma. And I like this study design because it's really going to ask the question, how does this agent compare to the standard chemoimmunotherapy? Another study that got a lot of attention at ASH is the inMIND study. This was a study of R-squared, lenalidomide, rituximab in recurrent follicular lymphoma versus the same combination plus tafasitamab, an anti-CD19 antibody that has been approved in combination in recurrent large cell lymphoma, now being explored in follicular lymphoma. You see the treatment regimen here on the upper right, basically 12 cycles of R-squared versus with placebo versus 12 cycles of tafasitamab. I'll point out there's a lot of therapy for a follicular lymphoma patient. Tafasitamab every 2 weeks, more or less for a year, weekly at the beginning and then every 2 weeks. So it's a lot of therapy for somebody with follicular lymphoma, a year of that for people who may be working and doing other things. So keep that in mind. Nonetheless, this was a pretty well-tolerated regimen. Otherwise, you can see the blue being the 3-drug, the green being the 2-drug. Minor changes, I would say, in toxicities, but generally speaking, very similar toxicity profiles, a little bit more with the tafasitamab-containing arm. And interestingly and importantly, progression-free survival, which was the primary endpoint, significantly better with the 3-drug regimen, including tafasitamab versus R-squared alone. So very interesting data here. And I'll just point out overall survival, premature, So far, not major differences, but again, we'll see how that pans out with more follow-up. So an interesting regimen for patients with recurrent follicular lymphoma. Again, fair amount of therapy, so it'll be interesting to see what group of patients fall more practically into this 3-drug regimen versus 2 drugs if and when this is available. Mosunetuzumab that I alluded to before in the upfront setting. This was an update by Mazir Shadman and colleagues looking at, again, this single-arm study of mosunetuzumab. This was a study of about 900 patients with 2 or more prior therapies, focused in here on the POD24 population. So I'll draw your attention to the lower 2 curves on the right. Basically, whether or not you had POD24, which is a less favorable situation for patients with follicular lymphoma, you see that the response rates and durability were quite good, whether or not you had POD24 as part of your profile going into this study. So again, mosunetuzumab, I think, an important agent for patients with recurrent follicular lymphoma. Also, we have available for follicular lymphoma the ZUMER-5 study, axicabtagene ciloleucel, so CAR T-cell therapies are available. This is one of them, but we have more than one looking at relapse refractory indolent non-Hodgkin lymphoma. This study zeroing in on the group of patients with follicular lymphoma in particular. You can see this is a summary for the abstract from Satva Nilpalu and colleagues. When you look at follicular lymphoma, the estimated duration of response was close to 5 years. Similar in marginal zone and follicular lymphoma. If you had a CR, which was the majority of the patients, it was even longer. The majority of patients were in remission 5 years or longer. You can see data at the bottom here around the progression risk and lymphoma-specific death. I think this is supportive data for some selected patients using CAR T cells in follicular lymphoma. I do think that most patients, and certainly in my practice, who are getting CAR T cell and follicular lymphoma will be those who have been through many of the other therapies we talked about, including probably R-squared, probably also a bispecific antibody, and then thinking about CAR T cell for patients with multiply recurrent follicular lymphoma. And then just to again mention AZD0486. This was the CD19, CD3 T-cell engager I referenced earlier in large cell lymphoma. In its early phase study, also looking in follicular lymphoma, you can see that the response rates, again, smaller study, looking at subsets of patients treated at different dosing. And you can see that this was an approach that resulted in high rates of undetectable minimal residual disease in patients with CR. So again, this remains an agent under active investigation. So in the last few minutes, I want to just bring you up to date with mantle cell lymphoma. Lots been happening in this area. There were some updates at ASH here. You've probably seen before, if you treat mantle cell lymphoma, the triangle study, which was presented by Martin Dreiling, updated at ASH, comparing a standard auto transplant approach versus auto transplant plus ibrutinib, the BTK inhibitor, versus chemotherapy plus ibrutinib without the auto transplant. So basically asking the question, if you add ibrutinib or substitute ibrutinib for an auto transplant, how does it compare to the auto transplant part of things? And you may have seen these data before. This has been published. This was updated at ASH. But basically the ibrutinib containing arms, whether or not you had an auto transplant, those are the 2 arms in green here, did better than the auto transplant alone group. And so if you get ibrutinib, basically you don't need to do an auto transplant is the takeaway, my takeaway from this study. And so that's, and that held up also in overall survival. Whether or not you had an auto transplant, if you got ibrutinib, your overall survival was better compared to the auto transplant alone sort of approach. Our group has not been excited about auto transplants for a long time. And I think those data support this. The other update that was presented, a subset analysis from Marco Ledetto in this study, different groups of patients, depending on where they were in the world, could or could not get rituximab maintenance. And you can see that regardless of what arm you went on, you benefited by rituximab maintenance. And so more and more data have come out in mantle cell lymphoma that rituximab maintenance has a benefit in a number of different settings. This was another late-breaking abstract, very important, I think. We have seen the field move away from auto transplant in first remission in mantle cell lymphoma. This was a national NCTN study taking patients who got whatever induction you wanted to give for mantle cell lymphoma, who went into a complete remission, and asked the question, if you're in an MRD negative CR, which is the majority of patients, do you need to do an auto transplant of mantle cell lymphoma? And you can see that arm A randomized to auto transplant plus rituximab maintenance. Arm B left out the transplant, just said, we'll give you rituximab maintenance alone. What's the benefit of the auto transplant if you're in an MRD negative CR in mantle cell lymphoma? This was designed around overall survival, and you can see that there was no difference. And so basically, you don't benefit from an auto transplant these days with regard to overall survival if you are in a CR MRD negative state. There's still some debate as to whether or not if you should do an auto transplant if you fall in the other situations. But the bottom line is that if you have a patient with a great response to their induction therapy, you don't benefit from an auto transplant. So less and less auto transplant in mantle cell lymphoma. I think that's good news for everybody. The other approach has been to say, well, what about using a BTK inhibitor, either alone or with rituximab and avoiding chemotherapy or adding it to chemotherapy? The ECHO study was presented at ASH, was presented at EHA and updated a bit at ASH. This looked at bendamustine rituximab in older patients versus bendamustine rituximab and acalabrutinib using the BTK inhibitor as part of upfront therapy. You can see that there was a progression-free survival benefit, a little more toxicity as you would have expected, adding a third drug. And when you look at different subsets, there's really at this point little in the way of an overall survival benefit, although time will tell there. When you look at different subsets, this was updated at ASH. Again, various different subsets, including perhaps higher risk subsets, seem to benefit a little more from the addition of the acalabrutinib in this study. And you can look at higher risk patients and a few other categories seem to benefit a little bit more from the addition of acalabrutinib here. That raises the question, what about in younger patients? Can we benefit from acalabrutinib in BR-based approaches? This was an ECOG-ACRIN NCTN study that basically randomized patients to BR plus Ara-C and rituximab, or BR, Ara-C, rituximab plus acalabrutinib, or just BR, acalabrutinib. And this study, you can see, had a number of different groups, over 100 patients in each arm. And the takeaway here was that there was no significant difference in progression-free and overall survival, and more toxicity if you add Ara-C, not surprisingly. And so kind of a negative study because there was no difference. But my takeaway here is that the acalabrutinib was easier to tolerate in combination with BR than Ara-C and had the same efficacy. And so if you want to add something to BR, probably not going to add Ara-C. I would be more inclined to add acalabrutinib because, again, the tolerability is better here with similar efficacy. That raises the question, which will wrap up this section and our talk in just a minute. Do you need the chemotherapy altogether? And so this is the ENRICH study, much as like in CLL. You've seen over the years in CLL, FCR type approaches versus BTK inhibitor approaches. This asks the question, ibrutinib rituximab versus chemo rituximab in older patients with untreated mantle cell lymphoma. This is over the age of 60. Now, the interesting thing about this study was that the R-chemo arm, you could either get R-CHOP, which is not a great approach for mantle cell lymphoma, or BR versus acalabrutinib. And so this was a positive study across the board. You see that ibrutinib rituximab in the orange beat immunochemotherapy with regard to progression-free survival. So you would say, okay, let's go with a BTK inhibitor over all chemotherapies. But in fact, what you see is that if you look at the R-CHOP control group on the left, ibrutinib rituximab was much better than R-CHOP. But in the subset of patients that were randomized to ibrutinib rituximab versus BR, the outcomes were quite similar. So to me, this says you could do one, you could do the other. You could even give BR up front and then give the BTK inhibitor second line and probably do pretty well with that as well. So again, I think this is giving more evidence that you could use a BTK inhibitor up front, but that BR is still a pretty good treatment for many patients. This has led, and really the last topic we'll talk about here very briefly is what about just using acalabrutinib rituximab as initial therapy and leaving out the chemotherapy? How does that compare to chemotherapy? I gave you some data around that from the ENRICH study. This is a study from the Nordic lymphoma group where they looked at a single arm study, and they looked at acalabrutinib plus rituximab. They included higher risk and lower risk patients and treated them a little bit differently. If they were higher risk, kept them on the therapy. If they were lower risk, stopped the acalabrutinib if they were MRD negative. This is 80 patients, median age 75. Small number, but some higher risk patients in this study. The takeaway here is that progression-free and overall survival on the right were quite good, and the overall response rate was in the range of 76% overall, a little better, 84% in the lower risk group, 62% in the higher risk group. And so again, in older patients, I think we're going to see more and more like we see in CLL, giving a BTK inhibitor, giving rituximab, and leaving out the chemotherapy is quite reasonable. And then the next step along this is really, and this is my last slide, that the question then becomes, if you adopt a BTK inhibitor-based approach, can you stop it? And so this is an alliance-led study where we're saying in older patients, let's use zanubrutinib, also a well-tolerated later generation BTK inhibitor with rituximab. And what we're doing is we're saying if you go into a CR, maybe you can stop the treatment and then watch. And then if you relapse, go back on the treatment and retreat at progression versus keeping you on the treatment continually. And so this is saying, do you get more mileage out of the therapy if you stay on it continually, or can you get away with stopping the treatment after 6 months if you're in remission, and then going back on it at some point in the future when you need it? So I think this is really going to drive another key question in mantle cell lymphoma, something that will be very important for our practices. And so hopefully I've given you a good kind of summary of where we stand in the most common types of lymphoma, large cell lymphoma, follicular lymphoma, a lot happening, treatments evolving, and particularly in mantle cell, moving away from chemotherapy and lots of new treatment options for our patients. And the good news is good outcomes and improvement in outcomes and new options for all of our patients. But it does make our world a little bit more complicated because we do have to think about these different regimens and learn how to approach all of these new drugs and how we use them in our practice.